about this, because if I look at 1.14 and you look, say under 5, that's all struck out. And we've already voted on it, approved it earlier, and on page 1, where it defined pain management practice, and we dropped the 30%, that's already been approved. And all this is struck out, and I think we struck it out because it was redundant.
Okay. Well, I
And
just.
on part A, that's about the ownership.
Well, yeah, that's what I'm saying. I just want to be sure there's no problem there.
Did you have a concern about the ownership?
Yeah. I mean, I don't know how that would impact practices. Because, you know, with the pain management practices, we've had issues with ownership, and I just want to be sure that we thought that through.
Well,
It's just one classification, I think.
Well, we changed from 50% down to 30%.
So that may mean some different types of practices. Yeah, no, it is.
Ownership of 50% or 30%.
No.
This
So-
talks about the ownership versus the percentage of patients. in
So that the
practice.
percentage of patients required to be a pain management practice dropped from 50% to 30%. So
Correct.
additional practices will be included as pain management practices.
So they have to register.
And so they have to register, and the ownership issue is a piece of the registration. So I just wanted to be sure that we considered this, before we move forward.
well, if you read the ownership thing, it says the pain management medical practice must, at all times, a majority ownership, 50% or more by a physician or group of physicians licensed by the board and or a hospital or healthcare entity registered by the Secretary of State to do business.
So it's
instead-
probably fine.
Yeah, because, I mean, my practice, I own a practice I never have. It's owned by a hospital, it's owned by a group. And so practices are either owned by the physicians or a hospital or some kind of healthcare entity. This was put in years ago when we first did
Yeah.
the thing, you know.
To prevent, private owners. I know that, I just,
So
wanted to
here-
make sure we considered it.
So here's a question then. If I have a practice and more than 30% of my patients I see, I'm prescribing pain meds for, do I have to register?
If you're treating chronic, non-cancer, non-terminal pain, acute injuries don't apply to the 30%, and cancer or terminal illnesses don't apply to the 30%. So it would be chronic.
That's what you're saying, like,
Rheumatologist, you know, and I mean, I hadn't spent a lot of time thinking about it, but I realized that there are gonna be more practices included in that definition. Okay, I just wanted clarification.
We're not currently in the business of tracking that. That's just gonna be something if it comes up in the investigation.
yeah, but we obviously had a rule and they're expected to follow.
Well, we've had a number, I don't know how many exactly, but we've got a number of licensees that on investigation appeared to be overprescribed. And when we did do the number on their practice, it was 48% or 45%. So we couldn't do anything, and the prescribing was inappropriate. It wasn't, you know, rheumatology practice or something like that. And this also keeps it in line with the bariatric practice.
So this is kind of, I guess, another way to hone in on those practices where lots of prescriptions are coming from. So, I mean, there was a lot of conversation about identifying those people who were kind of the source of the problem. And I think before what you're saying is that the regulations as they stood were liberal enough that those people were still able to kind of fly under the radar. Is that what I'm hearing?
Right.
Where are we now, Charlie?
We are on page 24, application for registration renewal, then training requirements for pain management clinics, and requirements for pain management certification.
We still have in there that, this doesn't, the CME doesn't have to be live. We didn't change that.
There's a category 1.
CME,
Just for,
that you can do.
We
100
took
hours.
out live format, that's gone.
yeah, the live is gone, it's just 100 hours of category 1 in pain management. And that's just one of the things you can do. You can do the residency, do other things.
But again, this isn't new, this is what we've been doing for
Right,
5,
this
6
is,
years.
this is old stuff, none of this has changed.
Which, by the way, I just subjectively, I think when we started this 5 or 6 years ago, pill mills were not uncommon in the state. Now, as far as I know, they virtually don't exist, at least the way they did 5 or 6 years ago. There may be practices that overprescribe, but, and I think the ones that do exist are under investigation now.
Any more question on pain management practices?
So, hey guys, so, you know, we asked about that, but if you go to 26, page 26, under 5, just to clarify, successful completion of 100 hours, so that is, it says interactive, that is supposed to stay live, right? And because live is there, live is taken out of the live lecture format for the completion of the 30 hours of CME for renewal. So, can we, page 26 at the top, number 5, I just wanna make sure before we move on that is what we intend, and that the live that we took out is the 30 hours for renewal, but not for those top
For the
5
initial.
requirements, right? And that's how we wanted to.
Yeah, that was my understanding.
Okay, just wanted to make sure, because.
For initial,
Was the last.
Right,
Oh, yeah,
that's where the
one
line.
of the 5.
Right, gotcha.
And the renewal CME has to be live.
No, the
No,
renewal
the
does
initial.
not.
No,
Right,
reverse.
Backwards.
yeah.
Happens. And page 27, which is the last page. Might say that the effective date of the rules now is gonna be as soon as they're approved by the Secretary of State. Gone.
Don't we have to, if we approve this whole body, don't we have to post it on the Secretary of State's website for another 28 days?
Yeah.
Because these are subject to change.
Yeah,
Yeah, these would not go into effect until they're approved.
And then even after they're approved, finally, they have to go to the occupational oversight board.
Correct.
So,
We don't know how long that's gonna take because we've never said anything there.
all right.
Randy. So that concludes what,
We have to make a
Charlie,
motion
I'm
that we accept the remainder of the document.
Second.
all in favor, say
I
aye.
got, Charlie, I got a question, sorry.
Discussion. Yes, sir.
I'm waving my hand, you just didn't see it. I'll make sure for process, that I understand. You're saying that these are substantive enough changes that they'll be posted to the Secretary of State's website,
Right.
and then be brought back for final adoption after that?
I don't know whether it goes to the occupational board and then would come back if there's reason for reasonable questions, or come back before it goes to the occupational thing.
I'm hoping that,
Can our Assistant Attorney General, give us an opinion on that?
She could if she was here.
She's not in the room, I'm sorry.
Stan and Rhonda are going.
Stan?
yeah, what I'm hoping is that the rules, once they're filed with the Secretary of State, will be reviewed by the occupational committee first, so because if they have any changes, I don't want to start, and any of those changes might be substantive, I don't wanna have to start the process over again.
Stand back and ask.
So what are you saying, Stan, these go to the Secretary of State?
I'm hoping, Rob, to make,
My understanding is whenever you propose them, I have to submit them to the occupational board, but they just to say, yeah, we've got it, then I file with the Secretary of State. After the comment period, and then if they'll come back to the board, and if you final approve them, then they go to the occupational review. So you've got to approve them, and then they go to the review, and if they approve, if they're okay with it, then it goes to the Secretary of State for final.
So, what I heard you say was it goes from here to the Occupational Review Board, then to the Secretary of State, then back to the Occupational Review Board.
Well, no, Secretary of State, then back to you guys
Right.
for a final approval. When you final approve it, then it goes to the Occupational Review Board for their approval, and if they approve it, then it goes to the Secretary of State. But I'm guessing if they don't approve it, it'll come back to you, the
Well,
Occupational Review.
I would think when it goes to the Occupational Review Board, any changes they make are final changes. I mean, we don't.
No, we haven't actually been through
They
that part
have
of it.
veto
but
power
that-
and everything.
So it goes Secretary of State's website, then it goes to us for final approval, then it goes to the occupational board, and they make whatever changes, and when those changes are made, that's it.
Do they make changes, or they send them back to us?
Well, it's still gotta be filed with the Secretary of State for the final,
it's
Approval.
really unclear how it's gonna come
for
down.
the
Yeah.
30 days or whatever. before-
Bottom line is, I don't think it's gonna be before the January meeting of the board before anything is
Yeah.
over there.
We don't know how this is gonna work exactly because we've never done this before.
So, so the process for now, if I understand it correctly, is if we adopt them today, they could potentially coming back to our January meeting for final adoption in that process.
Possibly.
When's the January?
Okay, possibly, right.
18.
What's today? 15, so you would have a 28-day thing if we posted it tomorrow.
Still have
Well,
to
think
do the
about
same
the,
vote.
Vote
Yes.
on the overall process today, because there were some that may not have been clear about whether we had the full vote, but if you take one kind of omnibus vote, that might take.
We're about to vote to approve everything we hadn't voted to approve yet.
And can I make a request?
Yes, ma'am.
When the document is cleaned up, can we all see it before, when all the changes have been made, you email it to us all?
Did you check notes on all this stuff?
Okay. Question's been called, seconded. All in favor of adopting these changes into 2640, say aye. Aye. Thank you, Bill. Now, that we're through with all that, we got a few minutes and I don't know, what, 3.5 hour drive. Are there any comments that are short? Anybody like to make? Yes, sir.
There,
Stand up and identify yourself.
happily, Wesley Newslager, I'm attorney with Mississippi Board of Nursing. This is actually not a comment directly related to regulations. I was just speaking with Stan here. Maybe I can give you all a little help and a little guidance with the Occupational License Review Commission. We've actually had the privilege of sitting before that commission. It's kind of a daunting experience with the governor and the Secretary of State and other representatives in attendance for its inaugural meeting of which it took action. What you can expect is to file your regulations with the Secretary of State as proposed regulations. Once you all have an idea, or excuse me, let me back up. You file with the Secretary of State. You will simultaneously file with the Occupational License Review Commission. Now, that commission meets quarterly to the best of my knowledge. Do I have those specific dates? No, I do not. In fact, we were notified approximately a week at best prior to their meeting, so it's hard to give you dates as of now. But quarterly meetings that would be submitted to the Occupational Licensing Review Commission. Your assistant AG representative could provide you feedback on what a working group of that commission actually thought of those regulations. I believe that there's kind of a vetting process, a working group, if you will, that will review that before it gets to the actual commission. So you would be in contact with your AG representative to find out how that working group felt about the regulations. You would then come before the Occupational Licensing Review Commission. In our experience, we were asked to present our proposed changes. Those proposed changes were discussed with any concerns expressed by the members of that commission. As Stan said earlier, they do have veto power. They also have the power to make recommendations to send back, and you even have the power to withdraw, as we have done on one of our regulations, if the feedback you get from that working group maybe isn't so positive. So it's not, I don't interpret it so much as putting it up and kind of either it's hit or miss. I feel like this is something that you work with the committee. That they are not there, in my opinion, in my very limited experience, to stifle your regulation. So I do think that there may be some back and forth that takes place. After and if you get that approval, then you would file your final notice of your regulation. 30 days from that, it would become final and enforceable. A lot of information. I'd be happy to answer any questions if you all have any questions regarding that.
Appreciate that. Very helpful.
Thank you.
Yeah.
Bad news is they meet court.
Dr. Ingram.
Fred Ingram, I'm a gynecologist in Jackson. I do very limited pain management with a select group of people with bladder pain syndrome, pelvic floor myalgia. The number one comorbid condition in that entity is anxiety. And I don't know how you treat a pain patient with anxiety without using both products. That's documented in the literature. And it doesn't say how you treat them. It's just that that's the number one comorbid condition in that medical chronic pain condition. And I have a number of people that own them. I've tried to get them off Xanax and put them on Klonopin. All of them are not successful, but that's a problem I have with a select group of people, is what you're talking about. The other thing is you're talking about doing your drug screening in the office. I have a number of them that are on Medicare, and you can't do an office drug screen and bill the patient. How do you handle that when you send it to the lab and it's an astronomical charge from the hospital lab? And I've got people who can't afford it.
None of the
What do I
things
do?
done here, though, is gonna affect how you're treating your bladder pain syndrome, because you can use benzos with opioids. It just has to be documented.
Documented.
You have to,
Well, it's
in
in
a
our
very
literature.
few.
And you're saying it could not be used on a long-term patient except in rare situations. Y'all spend a lot of time talking about that and saying that it's not recommended, it's a black box. I don't really care whether it's a black box. I'm trying to keep people out of the bed and being able to function somewhat. If you understand what I'm talking about.
Okay,
That's your job.
prescribing of opioids concurrently with benzos and/or Somlon may be allowed only under very limited circumstances, which the combination is used to treat very specific chronic medical conditions for which there's no other treatment modality
Okay,
available.
thank you. I just want to be sure that.
Well, that was there, that's what we voted on.
That's what we voted on.
The other people, man, that's the only kind of pain problem I see. Dr. Miles knows all that.
But you're gonna need to document that you've tried other modalities and this is the only thing
Well,
that
one of
works.
the modalities would be behavioral therapy, and insurance doesn't cover that, and these kids can't afford it.
Document.
Document.
Document it and do what you need to do.
Okay.
Well, seeing how there are no other comments. Bill,
No other comments?
another bill.
No, sorry.
I think my original comments before still apply. When I testified before you on November the 15th. I believe that the ask that we gave was quite specific, and I believe it's still apropos, and I believe this is tackling many things that, one, are not the governor's task force, and two, go well beyond what I thought the intended point was to help with opiate overdose and heroin deaths. And we've now morphed into changing everything else. And it was very obvious that although this was a working meeting, there was a lot of not togetherness, and I know it was a working meeting, but there was confusion even on the board about these things. I know you voted on it now, but I'll just lay it out there.
Bill, you do understand that these are old regulations. We've dropped this from 29 pages to 27, and this is a revision of all our rules and regs that we've been working on. So there's very little in here that is new. And, that the majority of what you thought needed change are the involved in the changes we've made.
I believe I heard that drug screening was still gonna be done, that's just one instance. There were several references, no, we're talking about Schedule 2 opiates, and the verbiage says opiates, okay? And so there are still some wordsmithing that at least should be done.
Can you be specific?
If I had a copy of it, yes, I probably could.
Well, that's all we've ever asked, be specific and address the line, the page that we're talking about, so we are on the same page.
When did I have the opportunity to see it?
Well, just to clarify, and we've said this in the past, but historically, we started almost 3 years ago rewriting all of our rules and regulations. When we came to chapter 2640, we shelved that in lieu of MSMA's task force on opioid and heroin. And then we took that and we shelved it until the governor's task force got through with their recommendations. Chapter 2640 is not a chapter about the governor's task force on opioid and heroin. Much, if not all, of the recommendations have been incorporated in this, but it's that and more. In terms of point of service drug testing, what we passed was point of service drug testing must be done each time a Schedule 2 medication is written for the treatment of chronic, non-cancer, non-terminal pain. And then we got into the point of service thing and we exempted hospice patients, and we said, so it's a Schedule 2 medication for the treatment of chronic, non-cancer pain. That does not include amphetamine treatment for ADHD. It's not mentioned there anywhere. It's Schedule 2 for chronic, non-cancer pain. Now, I don't know what Schedule 2 medication you're going to use to treat chronic, non-cancer, non-terminal pain other than an opioid. So.
And you said there was disagreement on the board. Yeah, this was a working meeting. This is how we get to conclusions. We may not agree until we discuss it, and it would be nice if we could do this behind closed doors, so it doesn't look like we're fighting each other. We aren't. We're just discussing things out and coming to a conclusion.
If you're in the board of trustees at the state medical, or if you're on a hospital board looking at bylaws for your hospital and revising them, that's all done in a single room with no witnesses. And we're having to do all our thoughts out in the open. So you're here to see the dirty work.
This is actually the first time we've met as a whole board to discuss 2640. I thought we did pretty good. There were no fist fights and no yelling. This is the first chance we've had to sit down and look at all this in one piece. And we probably have to look at it again before we get through it. His time schedule's right.
I think we have tried to address most of the comments, so you'll get an opportunity to see it back on that. We have, I think we've taken into consideration all the comments that we've got. That's really all for those, so that we can let the practices continue to take care of these. But at the same time, address some of the problems that we all know are going on. We must address them to protect the public, not to add additional charge to the questions on practice. Providing other care that we need us to do, but at the same time, we can improve certain it's a fine balance. We understand that. We're just trying to get to that correct.
Last night I took your 3 bullet points and went through these 27 pages, and I believe they're covered in the 27 pages, not all on the same page. Any other comments? Mr. Pompa.
Thank you, sir. Well, first of all, I wanted to thank Dr. Easterling for a number of the changes in sections 1.7, which will certainly mitigate some of the effects of this. I still think on net, it's unavoidable that we are in the top 10 for prescriptions. Mississippi is in the top 10 for prescriptions, but we are in the bottom 10 of the 50 states for overdose death rates. it's still unavoidable that on net, this will move us from the bottom 10 up the ladder, meaning more people will die and we will rank higher unless the other states are making changes like these that are faster or more aggressive than we are, which would keep us in the bottom 10. So I think that the net takeaway is, yes, this will bring our prescriber rate down, but it will bring our death rate up. And so my concern, which I've said before, so I'll keep it short, is as a result of these regulations, on net, somewhere between hundreds and thousands of Mississippians will die who would not otherwise be dead. Again, we will bring the prescriber rate down, but hundreds or thousands, depending on which math you use and which projections you use, would die as a result of this that would not otherwise be dead. And that continues to be my concern. But I wanted to again thank Dr. Easterling for a number of the changes that will mitigate some of those effects.
I agree. I think we have addressed that so that physicians aren't just throwing patients out of their practices without treatment. And so hopefully the things that we put in there that won't put the burden on the physician to just kick a patient out of their practice. We'll address that.
And I think it does to some degree. I'm still very concerned that, as I've talked to doctors, that with the Board of Medical Licensure, Bureau of Narcotics, doctors are, there was even confusion on this board as to where the regs specifically about detox and maintenance even live. There was confusion as to were those even in the regs or in statute. At the last meeting, it was clearly understood they were in statute when they were actually in regs. That's like a big deal, because that's a big deal.
They are in statute.
It's in both statute and the reg.
But it's not in legislative statute, which was the understanding at the last.
Federal.
No, right, but I'm talking about the ones we're specifically talking about were believed to be in state legislature control, and they're not. But regardless, even that, doctors are so opioid risk averse at some point that even though technically a doctor could say, I'm going to bridge you until you get treatment, many doctors are terrified to actually do that. So not only would they have to know that the statute changed to allow them to do something they've never been allowed to do for possibly decades, but they would have to know, they would have to be so courageous and so conscientious that they could believe they could leverage that statute without the Mississippi Bureau of Narcotics showing up and saying, hey, we want to check your books, people are terrified. So I'm concerned, although I think it will help to some degree, doctors are scared to exercise that latitude. And they're going to tell them, I could bridge you to treatment. I don't know the regs, nobody knows the regs, everybody's a little uncomfortable with what they exactly mean. I'm just not going to bridge you to treatment, I'm sorry. And that's when they go to the street. Again, that's a concern, and I know there's disagreement.
Well, it sounds like that's what you might do, but maybe not the physicians in the state.
Well, that's what the physicians who have approached me have said they would be uncomfortable exercising the latitude to do that. I don't know what percent of that.
Well, maybe when they read the new regs, they'll be fortified.
I am hopeful.
Yeah, what I think, and hopefully what's going to happen, is physicians are lifelong learners. And when you're in medicine, you start practicing medicine, you are continually learning because there's continual improvement in the practice of medicine. Our physician will, in my opinion, as I have seen over my career, our physician will get this. They will do what is in the best interest of taking care of their patients, and they will do it safely. And they will do it hopefully knowing that there is no Gestapo here or anywhere else going out to get after them, to do something about them practicing medicine. It is an educational process, and they'll get it. And they'll continue to provide good quality care to their patients. The majority of them will. Some of us are going to complain. We're human beings, but we will get it. We will modernize our practices. We'll be safe with our patients, and we'll move forward. We'll do something that we as physicians ought to be doing, taking care of our patients, while recognizing that there is a public health crisis going on, and we as physicians have to be a part of the solution. Will that be some inconvenience? Probably. But will we get through it and provide even better care? My career and my experience says that that's what physicians will do, because that's what we've always done.
And I think there's an educational movement too. I think the board maybe post something on its website.
Well, it's
to
clear.
Instruct physicians in this regard.
It's clear we've got 2 or 3 months, at least, if not longer, before this goes into effect. And so the licensure board would be more than willing to be involved in any educational process that any group wants to have. In reference to the last, I've always read that about the detox thing and thought it was strange. It never made sense to me, and I was always told it was in statute. Well, it is. It's in federal statute. So we've done all we can do. We've taken it out. Now, by taking it out, we took the 1 in 3 days, which was ours. By the way, that's 20 years old. That's nothing to.
Right.
So we've taken an effort to make it better. We've taken those 2 sentences out, but that does not mitigate the fact that if someone does this, that the federal government couldn't come down on it. Now, it's been our experience that they don't do that. I think if you talk to Mr. Dowdy and Mr. Fisher, they've got a lot bigger fish to fry than 1 or 2 doctors who are infracting this. I just can't imagine that they're gonna go after that. That's, but, you know, it is what it is. I want to make it clear for the record that what you said about hundreds dying is simply your uneducated opinion. You're not a physician, you're not an addictionologist, you're not a pain management specialist, and you derive this from data, which you're a lot better at than I am. But the number of deaths in any state is grossly underreported. So what you're going to see as time goes on is you're going to see death rates go up. Not because, in my opinion, what you said necessarily, but because we're going to do a better job of reporting. We see people all the time that pass away, and I related to you the incident 2 days ago. My son's going to Birmingham right now. Tomorrow he will bury a fraternity brother who's an attorney, who his father, who was his law partner, found him dead in the law practice bathroom with a needle in his arm. I don't know how that's going to be reported as death. I don't know what the coroner in Alabama is going to call it. A lot of times it's not called opioid related. Sometimes it is. So, be that as it may, I think comments like that are derogatory, and I think they're counterproductive, and I think those statements are made without any evidence. That's your opinion, and I want that on the record.
Well, forgive me, but thank you for the opportunity. But
I'm sorry, I was told I would have a couple of minutes to speak, and after hearing everything that y'all.
Who are you, please?
I'm sorry, my name is Susan Norton, I'm from Brookhaven, and I had interstitial cystitis. I was diagnosed in 1997, and I lost my career as an RN due to that, and had to move back from Memphis, back to live with my parents in Brookhaven. I have exhausted all treatments for IC and have been in pain management for 10 years. And I was probably being over-medicated, 60 milligrams morphine, 12 milligrams Dilaudid a day. I got cut off in September, and then my primary decided to cut me off Xanax, which I've been in ICU before trying to wean off Xanax. I've been in withdrawals for 5 weeks, and I can't get anybody to help me. They tell me to go to the ER. I've been hypertensive and tachycardic every day for 5 weeks. My blood pressure was 160/110 this morning. My heart rate was 113. And I'm in a dangerous situation, and the doctors are not doing what y'all are giving them the rights to do. They're scared to death. They're so terrified. They said that's outside of my scope of practice, or I don't feel comfortable doing that. I never tested positive for street drugs. I've never sold, crushed, snorted, shot up my meds. I was never short on meds. I returned prescriptions that I didn't fill. I never had a bad drug screen. I was drug screened every single month. They charged hundreds of dollars to Medicare for drug screens that they sent off to Texas. And what I'm hearing today is not what's happening out there with patients like me who have legitimate pain and need something. I don't need, if it was Tylenol in that work, I would be so happy. But sometimes it's going to be more than that. And I've had 10 friends in the past 14 months die that had IC who killed themselves within 3 months of getting discharged from pain management because they didn't know how to deal with it. They couldn't deal with the emotional effects of, the side effects of it, the chronic pain. It's like you feel like you have a UTI all the time. And I have generalized anxiety, and I've been being treated for that since I was 16. I don't know. I just feel like the state of Mississippi has thrown me to the wolves and literally to the street to figure this out on my own. And I don't want to die, but there's nowhere to land.
You see the gentleman there in the green scrub suit? You need an appointment with Dr. Ingram.
Dr. Ingram?
He treats interstitial cystitis and the pain that goes with it.
I've been seeing, well, can I say who I've been seeing? I've exhausted Paul Moore. There's nothing else he can do for me. Well, he didn't like anything.
This sounds like a good time for you to make an appointment with Dr. Ingram.
Thank you so much.
Make one other comment.
One other comment.
Last year, at the American County Pain Management, which I belong to, there was an advocacy group. There were 3 groups that spoke. And the lady that was in charge of that group said she had a number of her constituents said if they had their pain medicine cut back, they were going to commit suicide. This year, the Canadian Pain Society, which I belong to, there was a lady who'd been in pain practice for 20 or 30 years. They've already had 2 people commit suicide because of restriction on opioids. And that's the first time that's happened in their practice in 30 years. This is coming. Now, what he said is going to happen to some degree, but we don't know that. But that's what's happening in this country and in Canada. In Canada, they have heroin clinics where people can go and get their heroin to keep them getting from this contaminated heroin off the street. Yeah, can you believe that? They have a heroin clinic where they can go and get it. Blew my mind. That's not going to happen in this country.
Well, nothing was done here.
There seems to be a disconnect, and I continue to be amazed about this, that someone has derived from these rules and regs that you can no longer write on opioids. There's nothing in this that prohibits the responsible, evidence-based writing of opioids for legitimate pain. Now, if asking someone to jump through a few extra hoops prevents a physician from doing that, physician decides, or nurse practitioner, or PA, or whatever, decides not to do it, shame on them, in my opinion. You know, there are certain things you do in medicine. I don't need to tell you this, but if you got somebody on ACE inhibitor, you better check their potassium every now and then. You need to, you know, if you got somebody on a diuretic, you send them down to the lab, you check their sodium, you check their potassium. There are things you do. And we've arrived at this epidemic in large measure because the writing of these medications in large number unnecessarily has resulted in the #1 public health crisis in this country. So what this board and other boards across the country, by the way, don't think for 1 minute we're the only one doing this. What we're saying is if you want to treat chronic non-cancer pain with opioids, this is what you must do under certain circumstances. If you do it, fine, keep doing it. But people don't want to hear that. People want to hear that this board is stopping you from doing something. There's nothing in here that says that somebody comes in the emergency room with a kidney stone, you can't give Dilaudid or morphine. There's nothing that says if you have a total health that you can't go home with now 20 days of opioids and see your doctor back and get another 20 days. And I just think that this, you know, in my experience in dealing with this for the last year or so, a lot of the comments that are being made, both in the press and otherwise, are irresponsible. They're not what we're saying, and we just ought to stand up and tell the truth. We just ought to say what the rules say and let it be as is. And if a doctor decides they're not going to follow the rules and let their patients have chronic pain go without treatment, that's unfortunate, in my opinion.
I got into this because I would send them to the pain management doctor, they didn't want to take care of them. If they had a flare-up, you told them to go to the emergency room. And how much the emergency room costs? $1,000. My patients know if they have a flare-up, they call me, I will see them that day or the next day. I keep them out of the emergency room. All you need is a urine to see if they got an infection or a flare. And that's why I got involved too.
And nothing we did here will
No.
prevent you from doing it.
Well,
We think you ought to do that.
it's not easy.
It's not, is it? Any other comments that we can help with? Then the working meeting of the board.
I didn't mean to draw it. I'm sorry, I tried to be purely factual based on my understanding.
Yes.
That makes you